Good afternoon, and thanks Dan and Dana and Stages for the opportunity to be part of this excellent forum on the appropriateness of bariatric surgery. These are my disclosures. I don't think any of these have any specific conflicts with my presentation. And as I get started, I just want to remind the audience about the all-important Obesity Week, which is coming up about 9 months from now in Washington, D.C., and world's largest meeting focusing on the science and practice of obesity. So a lot's happened in the last 25 years since the NIH Consensus Conference on Guidelines for Bariatric Surgery, 1992, and that was focused strictly on obesity and based on body mass index. And about 2 to 3 years ago, it was updated. The NIH is out of the business of these types of guidelines these days, but organizations such as the Obesity Society, American Heart Association came together to update the guidelines, and they're a slightly enhanced version of the 92 guidelines, but have not had any fundamental change. But a lot has happened just this past year, specifically with type 2 diabetes. And these are the 4 common procedures that are performed throughout the country, and we've all seen a shift in terms of more utilization of the sleeve gastrectomy, but these new guidelines apply to these 4 common procedures. First, I'll just talk to you about the evidence base for the new diabetes guidelines, and I'll talk to you specifically about the new guidelines. So, again, in the last 5 to 6, 7 years, accumulation of a number of randomized controlled trials that were not present almost a decade ago when the initial diabetes surgery summit in Rome, Italy met to really discuss the role of surgery for diabetes. So we have this now a large body of evidence, and this is a forest plot showing you these 11 randomized controlled trials, comparing them with medical lifestyle therapy based on the mean difference in hemoglobin A1C between these 2 types of treatments. And you see an overwhelming support for surgery in terms of superiority over medical therapy, quite a high degree of consistency. These are all randomized controlled trials. There's only one exception, and that is the 3rd study by Ding and others, and that was a gastric banding study compared to medical therapy, and that was pretty much a wash there, but that it comes to no surprise knowing the results of banding with diabetes. But we do now have a high degree of consistency, multiple randomized controlled trials, showing level 1 evidence. Now we're beginning to see some of these trials mature with longer follow-up, and I want to share with you a couple of them, including this study by Geltrude Mangroni, Francesca Rubino, and others from Italy. This compares the gastric bypass with biliopancreatic diversion, and you can see these 2 key data charts, first showing relative weight loss, which comes to no surprise, quite stable weight loss with both the bypass and the BPD procedure compared to just conventional medical therapy. And then a major outcome endpoint was remission, which they defined as A1C less than 6.5% without medications, and obviously that was not achieved in any of the medical patients. Fairly high achievement at 2 years, a slight drop at 5 years, but with both of these procedures, between 40 to 60% of patients at 5 years are in what we would call long-term remission, which is quite remarkable. And I'll just briefly share with you the STAMPEDE trial, which is recently published as 5-year data. And the 1st year, 3rd year outcomes, and then the 5-year outcomes have recently been published. And there we go. And I want to point out that this was supported by Ethicon, LifeScan, NIH, and also support from the Cleveland Clinic. And this is one of the key slides here showing the relative changes in A1C from baseline between gastric bypass, sleeve gastrectomy, and medical therapy. And note that with both surgical procedures, quite a dramatic drop that is, for the most part, fairly stable over the 5 years, although there is a slight rise in A1C over time. But compared to the medical therapy, which did have a significant drop initially, but it's gradually going back toward baseline at the 5-year mark. And if you actually look at the patients at baseline compared to where they are 5 years later, Actually, more of them were worse off than had actually improved over the 5 years, despite fairly intensive medical therapy, much more intense than standard community conventional therapy as espoused by the ADA. Whereas with surgery, the vast majority are improved over baseline, and this is quite significant for a chronic disease that is known to progress over time, and only a very tiny percent were actually worse over time. And this shows you the relative change in body mass index, which is probably no surprise to this group, favoring surgery, and there was even a statistical difference favoring the bypass over sleeve gastrectomy. And very importantly, to these guidelines was the finding that patients with the lower BMI, the mild obesity and diabetes, fared just as well as those patients with the BMI greater than 35. And this is particularly important because most guidelines up until this time and most payers would not support the surgery for a BMI less than 35, even if it was 34.9, this sort of arbitrary cutoff. But this and other studies show clearly that these patients fare just as well. And then finally, one of the key benefits of surgery is better control with less medications, so a dual benefit. And this shows you at 5 years the medication requirements for both procedures compared to medical therapy. And note that even among these two procedures, patients who had gastric bypass required far fewer medications. In fact, 45% or close to half required no diabetic medications, so twice the amount for sleeve, and that was statistically significant. And only 12% were still on insulin, which in itself is a very important goal of therapy. Getting patients off insulin improves the quality of life. Now, just a few years ago, the American Diabetes Association had their guidelines, which were fairly straightforward and had not been changed in many years. And they basically pointed out that patients who have diabetes and have BMI greater than 35 might be considered for surgery, which is a very soft indication. Of course, they need lifelong therapy, and surgery was not for patients for a BMI of 35 or less. Then after the accumulation of all this data and a review at the 2015 Diabetes Surgery Summit in London, new guidelines came out, the International Guidelines for Metabolic Surgery, and they were published in this historic issue of Diabetes Care, the first time ever this journal of the ADA solely devoted their entire issue to surgery. And there's some 12 articles devoted to metabolic surgery, including the new guidelines. And these are downloadable if you'd like a copy of that. And these guidelines have very, very important implications. In fact, there are more than 30 recommendations that involve comprehensive aspects, including indications for surgery, perioperative care. They were widely endorsed by world major thought leaders, and a few of them are listed right here as co-authors. These are stalwarts in terms of diabetes thinking in the diabetes world, and also endorsed by more than 45 international diabetes organizations, including the ADA. And these are the key points right here that relate to indications. A much stronger recommendation now for a BMI of 40 or greater, and this is regardless of glycemic control, and recommendation is equivalent to the term standard of care. Surgery is now recommended between 35 and 40 if the patients are not well controlled on medications. And finally, for the first time ever, we have very wide consensus on lowering the BMI from 35 to 30, and surgery should be considered for these patients who are not well controlled on medical therapy. And then finally, lowering that BMI even further to 27.5, which is beyond obesity, which would be considered just overweight. For certain ethnic groups, particularly in Asia, such as China, India, these folks are much more prone to the deleterious effects of type 2 diabetes at a much lower body weight. So those are the key 4 new indications. And just this year, a couple months ago, the ADA completely endorsed those into their standards of care document that they published every year. And it's pretty much verbatim as the international guidelines. Surgery is recommended for a BMI of 40 or greater, recommended for 35 to 39 if a patient is not well controlled on medications, and surgery should be considered for this lower BMI group if they're not well controlled And obviously surgery should be done in multidisciplinary type centers with high volume that can improve their outcomes. So it's come a long way. Now, what are the implications for surgery? I think this is good news for patients. It's good news for doctors and care providers who take care of patients, and it's good news for surgeons because, currently, and this is fairly recent data, based on patients who are currently diagnosed and treated for diabetes, how they're actually reaching these targets of therapy. And you can see that altogether, less than 20% of patients who are being treated for diabetes are actually at the key targets of therapy, like glycemic control, blood pressure, LDL cholesterol. So surgery can now be one tool to help patients and physicians reach these goals, which have been associated with reducing long-term morbidity and mortality of surgery. Who are the preferred patients? Who out of all these patients do I personally think are going to probably come to surgery sooner? Well, I think those patients who are sort of at the crossroads between a life of insulin or surgery. And I think one can make a very strong case from a very conservative point of view that surgery has tremendous benefits for these people. And then finally, young patients who are diagnosed at an early age. We know this is a progressive disease. Diagnosed at an early age, an opportunity to actually have a long-term remission and avoid the long-term consequences of type 2 diabetes management. So in conclusion, there's now an abundance of evidence, contrary to just a few years ago, abundance of evidence, level 1A evidence, randomized controlled trials supporting surgery for type 2 diabetes, not surgery to lose weight, but surgery to treat diabetes. And now we have guidelines that are internationally endorsed by essentially all of the world's major diabetes organizations. So next step forwards are really, and I want to also thank, I mentioned the STAMPEDE trial, our key investigators who are involved with the study, Dr. Stacy Bretthauer, current president of ASMBS, Sangeeta Kashyap, a lead endocrinologist, and a couple of our key cardiologists, Steve Nissen, Deepak Bhatt, and many others, Aliyah Minion, for their support of this study. But I think going forward, the key now is adoption of the guidelines and addressing the issues specific to key stakeholders such as patients, referring physicians, and then finally payers. Thank you very much for your attention.